Okay, we're going to get started with our next oral session. And this talk is about xanthogranuloma by Dr. Guneet Janda from Mayo Clinic Rochester. The topic is patterns of presentation and outcomes in adult xanthogranuloma. This is a topic we've been talking about quite a lot today, so we're looking forward to your presentation.
All right. Thank you, everyone, for coming today and for giving me the opportunity to talk on our work, examining patterns of presentation and outcomes in adult xanthogranuloma. All right, so just a bit of background. So xanthogranulomas can be on the spectrum of the non-Langerhans cell histiocytic neoplasms. They are most commonly seen in children, where they are termed juvenile xanthogranulomas, also known as JXG. Less commonly, they are seen in adults, where they are termed adult xanthogranuloma, also known as AXG. Patients with XG can have heterogeneous clinical presentations, and there's really sort of a paucity of data on disease distribution, management, and outcomes. Okay, no worries. Predominantly, xanthogranulomas have been studied in pediatric populations, with sort of the largest series that I could find having sort of 170 patients with outcome data, but very limited sort of adult-specific data. But prior work did demonstrate that in xanthogranuloma, it is predominantly cutaneous disease that is the manifestation. Okay, so our objective here is we wanted to look back at patients with AXG and categorize the presentation, management, and outcomes. And to do this, we utilized the retrospective cohort study for patients diagnosed with AXG at our institution for the past 20 years. For our inclusion criteria, we specifically included adults who had a histopathologic diagnosis of adult xanthogranuloma. And of note is we excluded patients who had prior diagnoses of histiocytic disorders or patients who had sort of obvious signs of Erdheim-Chester disease at presentation. So if they had characteristic long bone findings on imaging, or if they had signs and symptoms that were really suspicious for ECD that prompted an immediate workup, those patients were excluded. And then we also excluded patients with necrobiotic xanthogranuloma because of the association with monoclonal gammopathy. And then for analysis, we used mostly descriptive statistics. We did do some inferential analysis with Mann, Whitney, and Fisher exact test, and then we used Bonferroni correction for multiple comparisons to control our false discovery rate. Okay, so this is our patient cohort. So we identified 105 patients with adult xanthogranuloma, and we broke these down by sort of the pattern of distribution. So the majority of patients had solitary xanthogranuloma. Fewer subset had multifocal xanthogranuloma, and then a different subset had periorbital xanthogranuloma. And initially, I had folded the patients with periorbital disease into the other two groups, but I separated them out after further review, just because these patients were sort of handled differently than the patients with solitary or multifocal disease at other sites. And in terms of demographic breakdown, their age, sex, and race were not statistically significant across three of the different subtypes. And then below are the sort of immunostains that were tested and how often they were tested and the frequency of positivity. And more on the immunostains. So here's just a graph that shows the different immunostaining. So as you can see, when tested, CD68 was uniformly positive, same as CD163. Vector 13A was mostly positive in the solitary disease group, less so in the multifocal and periorbital disease groups, but this difference did not reach statistical significance. And then for the rest of them, there was some sparse positivity, but notably BRAF immunohistochemistry was negative, as well as cyclin D1 and then CD34. Okay, so now going down into sort of the different sites of involvement. So on the left is sort of a mannequin that shows the distribution of disease in terms of for patients who had the solitary cutaneous disease, which is the vast majority of patients in our cohort. As you can see on the right, there's a table that sort of breaks down sort of where the disease is present across the different subtypes. Again, you can see in patients with solitary xanthogranuloma, the vast majority had cutaneous disease that is consistent with sort of prior data. Sort of fewer patients had sort of more exotic disease locations in the GI tract, nasal mucosa, and then one patient had a subcutaneous lesion. For multifocal disease, the vast majority had multifocal cutaneous disease. One did have multifocal GI disease, and then periorbital, they sort of were broken into their own subtype, and so they didn't have any at those aforementioned sites. They were all sort of in the orbits. Okay. So now it goes on to my next slide, which is additional workup by disease distribution. And so I think this is where it gets a little bit difficult to, I think, draw patterns, because typically a lot of these patients are diagnosed after they come to their primary care physician or their dermatologist with some sort of finding. They're diagnosed with the xanthogranuloma, and they don't see necessarily a hematologist or a specialist initially. And so for solitary disease, very few patients actually had additional workup. The vast majority did not. Only 2% of patients, so 2 patients had advanced imaging, so like PET-CT, a bone scan, and then 2 more patients just had basic sort of workup, which is an X-ray or just sort of basic laboratory work. Patients with multifocal disease, the majority of them did receive additional workup. The 2 that did not were actually recently diagnosed with systemic hematologic disorders, so they already had workup done relatively recently. And all of the patients with periorbital disease had some sort of workup. The vast majority of them, actually all of them, got advanced imaging looking for sort of systemic sites of disease. Okay, so now moving on to sort of the management of patients with solitary xanthogranuloma. So there was predominantly 2 strategies that were utilized by the treating clinician at the time of the initial diagnosis of xanthogranuloma for the patients with solitary disease. And so they were either excision and debulking or observation. And the patient cohort was split relatively evenly between these 2 management strategies, and sort of almost regardless of approach, the vast majority of patients did achieve a complete resolution. We had one case that was excised that initially was diagnosed as solitary xanthogranuloma of a subcutaneous lesion, but when they underwent sort of surgical resection, they were diagnosed as an atypical sarcoma. And then there were 3 patients who underwent observation for their solitary xanthogranuloma that had some local sort of progression of their lesions, but then they were excised and then achieved complete resolution at follow-up. And this data is over a median follow-up of right over 3.5 years of follow-up information available. Okay. So now going down to multifocal disease. So we had 11 patients. 10 of them had cutaneous disease, 1 had diffuse intra-abdominal disease, and we had follow-up data for 9 of them. Of these 11 patients, 4 patients had a diagnosis of a hematologic disorder that was associated with their xanthogranuloma, CMML, CLL, follicular lymphoma, and then 1 with methotrexate-associated lymphoproliferative disease. And 3 of these 4 patients had resolution of their multifocal xanthogranuloma with treatment of their underlying hematologic disorder. 2 patients were later diagnosed with Erdheim-Chester disease. Both of these patients had BRAF mutations, and then 1 patient underwent Erdheim-Chester disease specific treatment and had resolution. 1 patient with the diffuse intra-abdominal disease was diagnosed with histiocytic sarcoma, sort of down the line. 1 patient with an FGFR1 fusion was started on pemigatinib and then achieved sort of complete remission. And then 1 patient who had some nasal cavity involvement had resection, steroids, radiation, and they had relatively stable disease, and they had a KRAS mutation. Okay, so now moving on to our patients with periorbital disease. And this one I broke into a separate sort of table just because of the heterogeneity in management. So really, for our 8 patients in our cohort, the predominant sort of strategies were either sort of surgical resection, debulking, or steroids. And of these, most patients had a relatively even split of either stable disease or progression. One patient was diagnosed with Erdheim-Chester disease and then received ECD-directed therapy. Of note, one patient who received initially systemic steroids and then progressed was treated with rituximab and then had a complete response. Okay, and so this is just the genetic findings sort of across the different subtypes. I will say this is rather sparse in the solitary disease just because many of these patients did not get genetic testing. But in terms of a big finding, so the patient with who had genetic testing with solitary disease ended up being the one with the atypical sarcoma, so they had this complex chromosomal rearrangement. And then one patient with periorbital disease with a BRAF mutation ended up with the diagnosis of Erdheim-Chester disease, and then here's sort of the rest of the variants that were detected. And then of the patients with multifocal disease, 5 of them had positive findings on NGS, 2 with BRAF fusions, both were diagnosed with ECD, 1 with the PTPN, gain of function, that was diagnosed with the histiocytic sarcoma, 1 with the FGFR1 fusion that had complete remission on pemigatinib, and then 1 with a KRAS mutation, germline CHEK2 mutation. Okay, so in terms of our conclusion, so this represents one of the largest adult xanthogranuloma cohorts to date with natural history and follow-up data. Of our 105 patients, the most common presentation type was solitary cutaneous disease, which universally had excellent outcomes regardless of the initial management strategy. In contrast, multifocal and periorbital disease were frequently associated with systemic disorders, and sort of the take-home point is, for us, is that if a patient has sort of non-solitary xanthogranuloma, if they have multifocal disease or periorbital disease, then they would likely benefit from additional evaluation, referral, or treatment. And with that, I'd like to conclude my presentation. I'd like to thank all of my mentors, the team at Mayo Clinic, who have been fantastic, and I'm happy to take any questions.